Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about knee osteoarthritis, whether it's something we can prevent a total knee replacement, or are these patients doomed, and overall, hopefully, clinical presentation and some treatment. But before I get too much into it, Brandon, how's it going?
Going well, man. Good to be back here. We were both on actually little vacations there. I went to Mexico. You were able to go to Denver, do the lovely sightseeing that is Colorado there, and whatchamacallit, I think you're visiting a friend as well, right?
Yeah, I was visiting my bud since high school, and yeah, got to go to a concert in Red Rocks, got to see the Rockies play. So overall, awesome experience, and oh, you got to lay out on the beach, a little R&R.
Yeah, a little R&R, got a little tan, got the base for the year. We're ready to go. It should be goals to maintain this the rest of the summer.
Yeah, that's good.
I shouldn't say the rest of the
it.
summer. We haven't even started spring yet. Spring and summer.
Yeah.
Still freaking cold here in the Northeast.
I know it's awful, but hopefully, I mean, today seems to be pretty nice. Maybe you can pass off some of your tan to my employee John there. We've taken some recent photos in the clinic, and my man is see-through, and I hope he's listening to this podcast so he knows I just blew him up.
You're just giving him more reason for him to dominate you.
Yeah. Oh, I did crush him in ping pong yesterday, and I got on Instagram. So yeah, his smack talking is become a little bit more quiet of late.
Getting some redemption.
Yeah, a little redemption. And I bodied him up a little bit, a little wrestling, but he's got me in the mercy. His wrists just don't bend. It takes away the main move there. So
I forgot to say, we just got our hoop. We have to make a post about it. Actually, yeah. Alan was great enough to put it together. He's the handyman in the clinic because Lord knows I can't do anything. So we have a hoop. It's legit.
Yeah.
It's outside, 10 feet. We will be
outside.
Your and Cam's ass. Yeah, we have the those beams that hang low, and then the lights too. So kind of we can't put it in the clinic. It would definitely just break some lights and shit. So
yeah, we've already done that.
Put it outside. It'll be by the curb. We'll when it gets nice, we'll throw down. Nice. Maybe after one of the courses too.
Yeah. I need some redemption, He shows. I mean, I will admit my last basketball game, man.
I had leave it where it is.
Huh? No.
Where it is. Not gonna like what
I was tired. I was teaching all weekend. I
was teaching all weekend too.
Yeah, but I mean, this time I did a lot more of the talking. I'm gonna pull out any excuse I can handle there.
And what's Cam's excuse? Oh, he had a game like the night before. Okay.
Yeah, we're gonna go into our topic now.
So, yes, right. To our topic, we've decided to bring it back clinically. I know we've talked about a variety of things like we like to do on the show. Yeah, keep it variable. Keep it bringing our experiences to our millions and millions of fans. So we're gonna touch upon knee OA. When is it indicated to get a total knee replacement or partial knee replacement? Can we better help our patients, guide them through the treacheries of the medical world? Can we be an advocate? Can we find some things that can at least stave off surgery for a little bit, which it's indicated in some people, and then some people it's like, hey, you need to go get it. Can we become better at understanding when we should refer these patients out? Can we become better at diagnosing? We have our, clinical prediction rules. I use that in quotes to help us guide if somebody has OA, but that's not always, a steadfast rule either.
Yeah. So, but before I guess we get into this, I'm excited about this topic. I used to see a ton of knee OA. Obviously, my population has changed, but we still get it from time to time. But I was started off as more treating total knee replacements, and then my goal was to start to prevent them as much as I can. So me, I love the knee, so this should be fun. But before we get into it, let's get into our drinks. Brandon, what you got today?
Got rum on the rocks, my Bacardi, a hint of vanilla. That I believe this bottle was given to us from Manny. Manny, patient of ours. So he's been awesome. He loves it coming to us. He's always supportive of the entire staff. So big shout out to Manny.
Cheers to Manny. All right. So I am drinking today is Elcian, which I've had a couple of their beers in the past. Altered Contact, a tart IPA. Pretty cool art here. I never had this one, so it's gonna be a live taste testing. Let's see. This one rewires your perception of IPAs with its electrifying tart and juicy demeanor. Galvanized notes of orange, tangerine, mango, and pineapple. There's no turning back now. I like it. I love things that have mango and pineapple in them, so we'll see.
Where'd you get this one? Did you get it while you were away in Denver or no?
No, but I did go to 8 breweries and
They have a big brewery strip there, as you know.
They do. I mean, there's breweries all over the place over there. So we hit one on the way back from the mountain or 2 on the way back from the mountain that we hiked. And then there's just Denver's loaded with them. So we hit 8 breweries in like less than 3 days, which was awesome and taxing at the same time. So, but this one, no, I believe I got this. This might have been for our holiday party. They had like a holiday craft beer pack. So I think this was in it. That's where this came from. I'm pretty sure. So a little aged, 3 months, 4 months. But I'm drinking out of my son's Up glass, which I believe is in Phoenix. I think it was a good brewery from what I remember.
I have to make my way out to Arizona. I want to go on a golf trip out there.
Yeah.
We got to go to golf. Like, you need to play golf and we need to
All right.
go out on a golf trip.
Yeah, just need to make that. All right, that's it.
And then the ladies can go play amongst themselves and won't
Pool parties, whatever they do.
because we'll be out playing golf.
Yeah.
It'll be perfect.
Perfect. All right, I'm in. All right, I'm gonna start playing twice a week.
What are you doing tomorrow?
Oh
God, here off to a bad. All right, moving on.
Next week.
Moving on.
I'm gonna give this a. I can taste the tart. Not overly like, whew. Could be that the beer's maybe a little bit old. No, but it was Best Buy like last month, so not terrible. I'm gonna give it a 6.8.
Oof, that's the lowest rating I think you've ever given on the show.
Was it?
I think so. 6.8. Usually on the sevens, like
sevens and that sort of stuff. And their beer, Space Dust, is one of the best beers.
Listen, you don't have to try and
but it's whatever comes to mind. I say it out there, and
fine.
That's all right. I have.
You don't need to backpedal.
No. There's been one beer. I forgot whichever one was the one that was a yam style beer, and it first hit my palate and I was like, holy shit, this is great. And then as the show was progressing, it got progressively worse, but I already said the number out there. It was like it went from like a close to a 9, and then I was just like, by the end of the show I was like, this is like more like a 7 at best. So, but it is what it is. It's out there. I'm putting it up there.
I think you could change your from now on. You can change your score mid-show or at the end of the show by the time, because the palette changes as you go along.
Mm-hmm.
So it's like, hey, initially this beer's an 8.9, right? 8.9. But as we went along, it's gotten worse, or vice versa. Maybe this is a 6.8 and it gets up to a 7.5. Drunker you get, who knows, man?
I appreciate that. I'm now excited about this because it has happened.
Freedom, some runway to work with here.
Wow, it's like evolving over time. So this is exciting. So I'll even write in the show notes. Started off at this, ended with this.
You said something key, evolving over time. That's what we talk about on this podcast, right? That's what we're about. It's evolving. It's becoming better, becoming different, getting different perspectives. We're going to share obviously today our different perspectives on NeoA as it's kind of changed, and how we used to treat it now, maybe how we treat it now. I know you said before you don't treat it as much anymore. Obviously you got the racehorse stallions that you're treating. So but yeah, anyway, let's go. TKEs or TKAs. Sorry.
You do TKs with TKs.
You have to do TKEs with TKs. Yeah. But yeah, so Jay, let's lead with you, and I guess maybe what you used to do, being that you really don't see that population now, and I know you have some good some research and things that you want to talk about as well. But yeah, I think things have been changing over the past few years on how quick surgeons are willing to go into surgery with these type of patients. But yeah, kicks off, man.
Yeah. So I was, after my first job, my real job, as we've heard on the show, was in more of a geriatric senior style location. So I did see a bunch of total knees, especially earlier on, which I had a extreme dependence on prescriptions and previous medical imaging and such, which maybe even changed up my mindset, how I treated individuals. I definitely, if people came in with, that script that was like moderate to severe OA, I didn't really put up a fight per se to say, hey, let's try and prevent this, or prevent a surgery of sorts. And that was early on. Luckily, I hopped into residency pretty quickly once I was at BSR. But that was kind of the mentality. Was then that kind of changed up my mobilizations or what I had in the toolbox as well. So if I couldn't just push their knee straight down in more of aggressive pattern, and get their knee straight, or just passive range of motion flexion, get their knee flexion back, they were pretty much doomed for a knee replacement. And the place where I was particularly at was a large ortho group that was keen on replacing joints. So that, led to me have a large population of total knee replacements. And then through, residency training, getting more confident with it, started falling extremely in love with direct access and trying to build up a name and brand with that. Yeah, we started to see a lot of individuals before they saw their orthos or at the same time, and kind of pitched it as, oh, well, it's a prehab, maybe 4-year surgery, just like we do with our ACLs. But, view as an opportunity, maybe we can also prevent the surgery if unnecessary. So it started evolving that, and that became my, almost a challenge, or pretty much a challenge. I took it personally, like MJ. I took that personal. Anybody who came into the clinic that was kind of slotted for a surgery, because we started to promote, hey, do prehab. It was my goal was to prevent them.
Yeah.
Why that's the case, not to say, hey, PT is the only way, and maybe I get them a little bit better, but avoid the surgery altogether. No, if it means that you're pain free, I don't care really what the strategy is. I just know that the total knee replacement, those earlier stages, are very uncomfortable. It does restrict you. You're not. Some certain people have gotten to sprinting and returned to some sports and that sort of stuff, but let's face it, for the most part, people's lives change, and then the possibility of complications. We don't really think that all the time, but it does happen. I've had a handful of people that had nightmare situations, from basically just your basic contractions, all the way to strokes. Now they went in for an orthopedic procedure, and then their whole life's changed, and now they can't use one side of their body.
Yeah.
So that's my thought process of why I want to avoid it. But I'm not the type of person that's like, oh, let's beat a dead horse. Oh, you got only 1 degree increase. No, don't go for the surgery. There is a certain time and place for it, and we'll talk more about that. But that's kind of was my early evolution of things. And at one point, I would say residency fueled this, and maybe my ego was too high. It was like PT or nothing. And now it's more of a kind of a blend of, respecting the patient's goals, needs, and being more collaborative with other health professionals, where I can all right, you need this. I think you're respond well to this versus, you should go here. But let me throw it back to you, Brandon.
Yeah, I totally agree. And I was with you, and I don't know if that says much for us, but with the PT or nothing, the ego thing, I can fix you or quote unquote save you type of deal. But I kind of think that's an evolution in a clinician's practice, especially those clinicians that like really just try and be like all stars and like, you know, a stud, and like you said, build a brand, build a name, right? Like you pride yourselves on your ability to get people back when no one else has been able to. But then, you know, as you gain more experience, as you get a little wiser, as you realize there's other fish in the pond, um, you realize, hey, what patients maybe will respond,
Mm.
and what patients don't respond, you know, and that's what we're going to get into later as well. But you know, we have that kind of chip on our shoulder. It's like, well, I can get you better. We just have to do X, Y, and Z, right? And you want to challenge that patient buy-in, which I think is a good thing in a way, because you're not just taking the status quo, right? And again, that's what, you know, we try and preach on this podcast is, you know, just because another medical provider says one thing doesn't mean it's, you know, that's what we have to go with, right? Do due diligence and actually screen out this patient. Like how many times, and we've talked about before, like an image, an X-ray, and MRI shows arthritis or shows some type of tear, but that doesn't mean that's necessarily the cause of the person's pain or problems. And same thing here. And Jeremy's going to go over a little bit, you know, some of the factors and impairments we should look into for these types of populations. But you know, even still, can we modify these things? Can we change these things either for the short term or long term? Another, you know, thing that I think is negative in the research, like, we want these long term studies. Like there's so many variables in or looking at long term outcomes that it's not fair to say, oh, PT didn't work when you have years of faulty movement mechanics, poor lifestyle habits, things like that. Somebody's overweight that you're just not going to be able to turn around. But can we provide a window of 3-6 months of relief for that person? Maybe they retire in a year, and we just need to get them to the point where they can retire and then get surgery, instead of trying to, you know, that home run approach, all or nothing approach of trying to get them better and completely avoid it. So I've changed as well. I used to have that mentality as well. I've also, and maybe this is just my perspective or wisdom or experience at this time, you know, 10 years ago when we first started, I feel like, you know, I was like, oh, you have knee OA, you're getting surgery like right away. I find now that surgeons tend to be more lenient with this. Okay, try PT first. Let's try some injections. Let's try to space this out. Let's make this a last resort type of thing, which I'm seeing more of. Or hey, let's maybe only do a partial knee replacement versus a full knee replacement. Hey, you only need one knee replaced. Let's just do the one, where it used to be, hey, let's do this one now because you're never going to come back for the second one if I do this one. You know, that was the mentality. So they were getting bilateral knee replacements at the same time, right? Which is awful.
Rough
and then one
years.
would always lag behind, right? So I think some of that's driven by what the insurances are reimbursing the surgeons too. They're not paying for dual surgeries where they get to bill out 4 surgeries in one time. So that might be playing a role into it. But hopefully it, you know, I'd like to believe that, hey, we just have the data that shows that it's not surgery isn't the fix that we thought it was.
Yeah. I did not miss those double knee replacement days. The double hips weren't terrible, but they still weren't the greatest. It's just too much for the body to handle, to be honest.
Yeah.
And even I remember having those people, and I extend their sessions to probably 2+ hours just so they can get, I was focusing on both. And even that wasn't enough. It's just way too much. But I think you brought up some really great points. I mean, it shows that the whole medical profession, you know, whatever discipline is growing and evolving. I remember my mentor had a patient that went in for an X-ray. It was like subacute pain. That was a big problem. It's like, it's one thing if you had chronic pain, you went through bouts of physical therapy. I always debate that, you know, what was the quality of therapy? If you're getting hot packs and, you know, some high school kid was running through exercises, is that really physical therapy? No. But let's say, you know, there's, you know, you did some exercises, you tried some things, and it's just chronic, you've dealt with it, it changes your quality of life. Okay, go for it. But I remember some people were, you know, they would go in, they've just had pain for the first time in their knee, and they get an X-ray and they're like, oh, it's severe OA. It's bone on bone. You got to get it operated. And let's look at the other one. No shit, that one's bone on bone, but let's look at the hip. And I remember one patient, went in with just some subacute knee pain and then
Coming out
left.
with 4 hip replacement or 4
Yeah,
joint replacements.
said the surgeon said we need to replace all 4 immediately. Like, imagine that. Just you're just going in like, oh yeah, I think I just tweaked something, maybe I get an injection or PT, but was told let's replace, we need to replace everything. Patient was thankfully resistant to that idea, had the PT, did great, no replacements anywhere. But it was crazy times back then. But I thought you brought up a good point about our research and our the constant look for some long-term changes and or differences. I think short-term effects lead to long-term changes in behaviors. My grandma used to always say, like, I can't do things, and she was obese and had diabetes and all these sort of things. But she couldn't do much because she was in pain. If we can help eliminate people with pain, maybe especially those ones who really need lifestyle changes, who are overweight or sedentary lifestyle, we can get them to where they aren't in pain and start to encourage them and use the exercise portion of physical therapy as a segue to staying active. Yeah, not everyone's going to do it. That's in a way of like preventing these surgeries, and we don't get credit for that, especially in the research. So, it's something I think we need to give ourselves credit for. There's been a couple patients unrelated knee OA where recently the patient expressed that PT changed their life, not just from a pain perspective, but also from the mental cognitive side of things. But think about that, guys, when you're treating your patients and that sort of stuff, is what's the impact in the long term? Is it, I'm treating and beating a dead horse, trying to get, 1 to 2 degrees that don't sustain in between sessions and extending their rehab months and months and months to the point where they hate PT and then they end up going for operation? Or, that's changing their life in a negative way? Or, I'm doing some things, I'm clearing them out, I'm preventing them a surgery and preventing any, loss of function as well. And so many people change up their life because of major surgeries. So if we can hit them early, and I think that's something that's exciting, people still don't know. I mean, every time I have the conversation with someone random off the street about the fact that we do direct access in physical therapy, it's still surprising to them. But you are seeing more and more and more of it. And I hope that becomes our cycle. Is like, if we can get these people early, then, can we prevent that whole process? Dr. Howard Lukes just put up a blog or a website, a website blog, how he said you can't unsee your image. But like, it's not one thing that, all right, we can explain to someone, hey, no, this is fine in asymptomatic individuals, but still planting that seed, you can't unsee it. And how much that affects people's lifespan, for instance. If we can see those people direct access, whether it's a total knee, stiff knee, whatever it may be, get them and say, hey, you just have some range of motion loss, maybe some weakness here or there, or some things that can help better stabilize knee, whatever you want to say, or ankle mobility issues. Can we, make a quick change, get their confidence back, get them back into activity, and avoid the whole X-ray that says they have, moderate to severe knee OA. An article I did not pull up that I probably should, while Brandon talks, was I believe there was a study of individuals who came in with single-sided knee pain, and then they got X-rays. And I believe 60% of the individuals had more arthritic changes or severe arthritic changes in the non-involved knee compared to the involved. I'll have to go look up that study, but I remember that. I remember the percent. I'll go get that. And that was like something I saw all the time, was so many patients would go into the orthos. And again, this is back in the day. Now things have evolved for the better, but they go in and the doc would be like, so your right knee hurts? And they're like, no, it's my left knee. And the doc like looks back up and it's like, no, it's the other knee. They're like, no, it's not. That's just how it is. So we can't over rely on imaging. And I think we're starting to see that change. But to avoid the image altogether, sometimes maybe the way to go.
Yeah, Jane, you have the article up there. What's the guidelines or clinic prediction rules to help rule in or rule out knee OA?
All right, 1 second. Let me
And
find it.
while you were looking up, or while you were talking, I was looking up the whole weight reduction thing. There is an article by Christensen in '07 that talks about weight reduction helping with pain for knee OA, and that number is about 13 and a half pounds, like 6.7 kilograms, right? So multiply that by 2, right? So you're looking at around that 13 pound range. So talking to those patients that have poor lifestyle habits, and maybe it's not done in PT, maybe they have to be referred out to a trainer or something that you work in the area, or for all you performance-based PTs out there. This is, where you get to, shine and hopefully get that patient to buy in and set a goal and set a program, create a program for them where they lose 13, 14, 15 pounds, and that should help reduce some at least the stress and pain going through that knee. And then you couple that with some manual therapy to help begin to load that joint again, and then some exercise to strengthen it up, and hopefully you're able to make some progress.
On a related note, and talking about conversation piece, and we have a conversation patient education communication course coming up, right?
Yes, we do. May 21st. It's a webinar, free webinar. Please sign up. Check out our Instagram. Our very own Dr. Kyle Feldman is going to be presenting that one. That's one of his passions. He loves I guess 2 to 3 things, and it's manipulations, dry needling I'd put up there, and he loves patient communication and clinical reasoning. Like, those are his wheelhouses. He's really good at that stuff. So definitely tune in to him. And he's unlike me and Jeremy, he speaks very well. Very well articulated man.
We're getting better. We're getting better.
Yeah. Yeah, check that out.
I brought that up for a point. You brought up like the weight loss and everything like that. Brandon, how blunt are you with your, let's say, your morbidly obese patients? They got knee pain or hip pain, and that their overweight is significantly impacting the cause of their pain, or maybe is the sole cause of their knee pain. How blunt are you about saying, listen, it's because you're XYZ overweight? I'm just curious, because I have something that happened to me yesterday.
So luckily, nowadays, especially, we used to just shy away from it because I was probably too. I knew I was going to be too blunt, and so I just didn't know how to have a conversation. But luckily now I've been able to learn how to like get them to ask the question. Or a lot of times, actually, even the patient will say, "Oh, well, I know my weight has a lot to do with it," right? Even if it may not, they may think so. And it's like, oh, well, that's a great conversation piece. The patient gave you literally the breadcrumb to go and talk about it and say, all right, no problem. Like, well, research has shown, a reduction of only, 13, 14 pounds will help your pain significantly, and then break it down. And it's like, that may seem like a large number. It may not, but let's just take a pound or 2 a week and we can get you there. No problem. Like, I can do this X, Y, and Z on the exercise side. We'll get you on the bike, we'll get you on the skier, we'll get you on some low impact stuff. And then if like eating is a problem, maybe go see a nutritionist. Then you have all the people, I have a thyroid issue, I have this, I have that. A little bit deeper of a conversation. Maybe they have to be sent to, endocrinologist or something to get, medication and things like that. I would say, sidebar between our professional colleagues here, most people, right, who take good care of themselves probably don't have all these thyroid and hormonal and balance issues and stuff like that. Don't get me wrong. There are outliers. There are people who do. But for the most part, the people with high blood pressure, the people with thyroid issues, the people with diabetes is because they have decades of poor lifestyle habits. That shit just doesn't fucking happen. But anyway, everyone likes to, especially in this Me Too world, and likes to just kind of be soft. And let's be real, make better choices, you'll probably be okay.
Mhm.
Anyway, a little soapbox there. You don't know
Yeah,
why?
no,
Because you don't know why. This is totally going off
yeah, it's
tilt here.
okay.
And
That's
I'm
people
doing
like it
I think
apparently.
like a fellow thing tomorrow or Friday, whatever days today. And I think I'm gonna do it on a topic. Just a bunch of softies out there these days. I'm sorry. Like I saw a post on Physiogram, and they posted some Joe Schmo saying that they wanted to be a PT or go to PT school, but they were afraid of the workload and being burnt out even before they got licensed. Like PT is not the profession for you, bro. You're fucking soft as fuck that you want an easy ass program. Like, yeah, it's hard. It sucks. Not gonna lie. We've all kind of gone through it, but it's school. It's a medical profession. You're not gonna have a cupcake coursework to work on people. Like, it's just mind boggling. Like, and they're complaining about it, like, then it's not for you. Don't become a PT. I'm sorry. Like, you're the person, you might have the grades, but your personality and your mindset sucks. And you're going to be a shitty PT because you're worried about being burnt out as a 22-year-old applying to a fucking program. It makes no sense.
I don't know. I'm gonna add in, so I'm gonna connect some dots here while I brought up the whole thing. So where I'm at in my new office, at Jet Training, and Ed, he trains a lot of the local firefighters because he is a firefighter. And we had while I was coming into the office, one guy pulled out of the intense training that they go through. So he puts them through like regular training and then training with their masks, and then adds like their gear and then adds the pack like week by week. Great exposure. It's great. But this one particular gentleman has been struggling. And he's easily over 300 pounds. His dad's apparently a firefighter, who's like a stud and everything like that. But like I had to like look at his knee and everything like that. And he's struggling, and like it was almost like paint the picture for him is that, this is a high intense thing that you have to do. You have to, I think their gear is 50 to 100 pounds.
Yeah.
You have to carry people, you have to do all these things, you have to go flip stairs, you have to, hoses. Some people are just not built for certain professions, or unless you make this lifestyle changes. Or for PT school, you gotta put the grind in, you gotta study. We can't be giving out doctorates to everyone, and we can't, have firefighters who aren't,
conditioned,
physically active or conditioned, going into fires where there's little oxygen availability and that sort of stuff. So yeah, I mean, it was interesting. I did all the things in the knee, and I was like, instantly though, my clinical decision is like, this guy is, probably working harder than he has in his entire life, and that's why his knees hurt. Like there was no trauma or anything like that. So yeah, I kind of agree with you on that. Hopefully I can hop in on that conversation tomorrow. And in this day and age, it's tough to call people out on these sort of things. That's the problem. It's like back in the day, you used to be like, yeah, you're overweight, you're not gonna make it, or you didn't put enough time into study to get into a program. Now it's like you can't do that. And I think that's leading to more issues, to be honest.
And COVID has only perpetuated the softness. And every time, a student who's not doing well, oh, well, be nice to them. They were a COVID class. All right, granted, yeah, that's a thing, but doesn't mean you get to suck and not know your shit because you had COVID, or not you had COVID, but classes were online and stuff like that. Like, find another way. There's things have really been open for about a year and a half now. Like, how long we're gonna ride the COVID excuse for?
And there's plenty of stuff, especially in our profession, which you can read that should get you prepared. So especially for differential diagnosing, these are articles easily available online. So but I guess we should digress here. Back to knee OAs, but yeah, that was a particular patient with knee pain, so kind of related. Something that you brought up before about, like, potentially some other things that can influence things. Another study that I'll bring up, because also my clinical evolution, the beers, it's slightly better. We'll give it a 6.9 though. Oh, I don't want to be too generous now. I'm sticking with my guns. I want to be a
all right, yeah.
a flip-flop flake.
Yeah, you only have to give the update if it actually changes.
Yeah,
I mean,
it is a little bit better.
a little better is not better. We've talked about
Yeah.
that.
Oh,
right?
good point.
A little
Good
better is
point.
not better.
Thank you for calling me out on that. And
Yeah.
see, I appreciate that feedback. I'm not
Yeah.
going to shy away from it.
There
You
we
know
go.
what? You're right. I was trying to, appease this company that's probably never going to even know that we did this.
Yep.
6.8 is a final answer.
Yeah.
But in evolution as well, as a clinician, I was, we've mentioned this before, is I was, we all do as clinicians, we get hyper focused on the problem area, especially when we have radiographic imaging suggesting some pathologies to the area, and why a lot of my patients maybe weren't able to prevent the surgeries because of that overly focus on it. And I was doing that the best of my heart. I was like, I'm gonna do everything to a knee possible, whatever, mobilizations, exercise, whatever it may be, to help that out. And a lot of times, even with knee OA, their problem could be elsewhere. And this goes into the whole thing. You probably have all gotten it out there, is you get someone who's had a replacement surgery and their pain is exactly the same pre-surgery to post-surgery. There's post-surgery pains and recoveries, but when the quality of pain is the same, that's when something else may be going on. And I'll hold on, need to pop up this cluster for the hip. And this is probably some of the reason why some of my knee patients didn't do so well, is again, you x-ray anyone over the age, it says 50s, I'll say in the 40s at this point, especially as imaging keeps getting crisper and crisper. It's just like looking at a regular TV versus an HD TV, and we're like, shit, how the hell did we watch this?
4K. Now there's 4K.
Yeah, 4K. It's like, damn it, it's like crisp, but you're gonna find more details in all our imaging. So I say anyone in the 40s. I've had some people as young in their late 20s being diagnosed with OA. But something to consider is potentially some variables, especially the hip. We always think things can refer down. And I'll throw in, they haven't developed a CPR specifically for knee OA for the low back, for potential low back. They've done it for patellofemoral pain syndrome, but I don't know of one of the knee for low back or knee OA. But some variables, hip or groin pain. How many of these people are like, especially that particular individual that I mentioned before, that get x-rays on all 4 joints, maybe had some stuff in the hip, but passive knee flexion less than 120 degrees, anterior thigh pain, more thigh pain versus pure just knee joint pain, a loss of internal rotation, pain with hip distraction was a CPR that was developed to suggest maybe adding interventions to the hip will alleviate things into the knee. And let's think about your differentials, leg calf perthes, skiffies, a lot of those things refer into the knee. So let's have this stuff on our radar and take it one step further, look at the back, look at the ankle as possible impairments or causes of their knee pain. Let's not just purely rely on this image, especially with the knees. I talk about that with ACLs and every other knee condition. Is a lot of the causes or influences of knee pain or further joints. So just wanted to throw that out there, reel us back into the knee OA discussion.
Yeah, 1000%. We always talk about treating regionally, and a lot of times we get a lot of our bang from treating regionally because impairment to other joints will cause increased stress to an area, or site of pain is a liar. A lot of times the patient's main complaint is pain, not the fact that they have OA, right? But then they get labeled with, oh, okay, OA is the reason why you have pain, and it's like maybe not always true. And don't get me wrong, in some cases there are, right? You have like that criteria, bone tenderness, bony enlargement, right? Those are things that you want to be able to look at. And then also, that's knee OA, tibiofemoral OA, and we have to be cognizant of the patellofemoral OA, which oftentimes just kind of gets lumped in there. and, being able to have that conversation with your patients of, hey, no, this isn't knee OA, this patellofemoral, this is this joint versus, the tibio-femoral OA, so that might help you with your conversation of, where that patient might get injection or where your treatment is, right? Mobilizing the patella, trying to distract that patella might give you more bang for your buck than working on the knee. Working on the quads, right? A lot of soft tissue to that area. Like, no, we need to get that joint moving better. Combine mobilizations in different areas, especially for the, tibial extension, adduction mobilization, right? Or can we gap that that medial side of the tibia and from femur region where a lot of OA is there? Does that give them relief, right? And there have been studies that shown, booster sessions work, manual therapy plus exercises work. And then there are studies, probably more so as I've looked at the research, that really says that at least long term, and we're looking at a year, manual therapy and exercise isn't beneficial long term, but it's beneficial short term. And like Jeremy said before, well, what can we do in the short term to make some changes to allow them to not have as much pain, so we can begin to load them and strengthen them or improve their functional status, so they can do X, Y, or Z. Maybe that person, that's all they need. Or maybe that person's going to retire in a year and just needs to get to that point where they can retire and have more time to then get the knee replacement. That's where our evolution has come in. It's like, hey, we're doing our job here. In this case, it's cog in the wheel. Like, we have to play our role. We're not going to reverse 30 years of knee damage, OA, and things like that. And that person's not going to need it. As much as it pains me to say, it's realistic, and you need to be able to understand it as a therapist and make that referral out, or have an honest conversation with a patient. Hey, we're going to do X, Y, and Z. If we don't see a change within, a month, 6 weeks, 8 weeks time, let's get some injections. Let's do X, Y, or Z. Gel injections, not corticosteroid injections, and let's see where we can go with this. They may need the surgery. So
yeah, and that's okay. I think that's why I always mention to like my students or even patients when I get on a real rant is, I hope as research continues to develop and we become better clinicians, is that, yeah, everybody's unique, but hopefully we can get to a point where almost every intervention subgrouped. Like, we know when's the best time to hit each particular individual that presents with, ABC, with that intervention at that time. And it's going to take years of research to develop that. We started to with a lot of these treatment-based classifications and such and so forth, or CPRs, but and they're under a lot of fire, but we can't just stop there. If we keep doing it, we'll obviously there's ebbs and flows, and there's people are in multiple groups and that sort of stuff, but we need to develop these sort of things, and especially when it comes to things that are especially more invasive. But even physical therapy, it's like, oh, okay, let's have everyone go physical therapy and delay things for a long period of time. And let's say with what Brandon say, like, you messing up someone's retirement, or wait for someone's retirement, or they start to progressively get worse and they miss on their opportunities. Let's say they're getting more contracted and losing range of motion. No, probably would have been better to maybe have that surgery earlier. So, you have to have you have to be humble enough to know who needs a surgery or who needs other intervention. And then you're going to help them along the way, regardless, for the most part. You're going to help them quarterback the situation, or you're going to see them post-op. And they'll respect you for, sending them in the right way. And sometimes we mentioned on the show is like, listen, we're working with things. There's no guarantees. We'll try out for a couple of weeks. And then as a couple of weeks going, you're maybe not seeing as much change as you're hoping. And then you say, hey, I want you to go see the surgeon or orthopedist that you trust. That's also kind of like-minded. It's like, I'll only operate when I feel like it's necessary. And then, they schedule that, and maybe a couple more weeks go by, and maybe they start to cope. Things change. A lot of their life stressors are now gone, and more just the fact that you're hammering things and staying consistent with things, that get better. So, these sort of things happen. Sometimes we put a rush ourselves to get things done in a week or two, and it does take more time. But you set them up where they have all their available options right from the get-go. So, just consider that with your care.
Yeah, I just want to wrap up. You touched on a great point. It's where we need to really continue to go and improve. We talk about patient education, patient communication, therapeutic alliance. As we see more people, as in general, as the profession grows, as we become more of a direct access option, and even if people come with us or referral, like we always talk about, we get more time with the patient. Well, we need to really utilize that time that we're able to spend with the patients, whether it's one session at a time, because you can see them for half an hour, or the fact that we're seeing them for a lengthier stay than a physician will, is, like you said, quarterbacking that patient, being able to be the kind of that point person for them and give them the options. And I think that really comes down to knowing your stuff, and not just being a nice person. Yeah, that helps to do that, but you need to know, if the call you're making is correct. Are you putting that patient in the best decision? Are you being transparent with them and open with them? Like Jeremy said, on the long run, that's only going to benefit you. It's how both of us have built our practices, by being open and transparent, direct at sometimes having these difficult conversations, but it's paid off. But I think we're able to have those conversations because we've spent so much time to hone our skill set, take our profession seriously, in the beginning, and wanting to be, having that chip on our shoulder of wanting PT to be the first and hopefully only stop you make. Obviously we've changed and we've evolved, and we understand that not every patient needs that or requires that, but at least that we have that capability.
Clap up on that one. That was excellent way to wrap this up. I think that's a good way to wrap things up, unless there's any other more nuggets of wisdom here. One last thing, definitely try it. If you're in an area where it seems like nobody tries PT first for any knee OA, it's like you're only getting people that get the total knee replacements, and then one of your follow-up questions are like, did you have physical therapy first? And they keep saying no, then maybe start going out and educating your community, the local surgeons, just to test it out. If anything, worst best case scenario, it's prehab. We know prehab, especially for knee pathologies, is effective, leads to better outcomes on the other side. Just start educating people, try and get them in, and great. If they respond extremely well and don't need surgery, great. You just save tons of insurance dollars and tax dollars and the person from additional risk. And if not, whatever, they go for the surgery, but they're probably going in a little bit better. That journey, that uncomfortable journey, is probably a little bit easier.
Yeah.
So that's something to add to the table there. But awesome discussion. Hopefully you guys got some nuggets of wisdom there for your knee OAs. And thanks for tuning in. And cheers everybody.
Cheers, guys.